General examination. In general examination of the respiratory system, we have to check for build, nourishment, dyspnea, cyanosis. Mode of onset of respiratory disorder determines the presence or absence of cyanosis. In acute respiratory disease, lesser area of involvement can result in cyanosis, as occurs in lobar pneumonia. Anemia may occur when there is hemoptysis, excessive sputum production and protein loss, loss of appetite leading to malnutrition. Jaundice may be seen with pulmonary infarction, iatrogenic due to certain drugs, liver secondaries or obstructive jaundice, pneumococcal, pneumonia clubbing, lymphadenopathy, eye, pedal edema, which may be seen in cor pulmonale, hyperproteinemia due to protein loss in sputum. Clubbing. It is a selective bulbous enlargement of the distal portion of the digit due to increased subungual soft tissue. The normal angle between the nail and the nail bed is 160 degrees and is known as Lovibond angle. The minimum duration required for clubbing to manifest is 2 to 3 weeks. Clubbing first appears in the index finger. Grading of clubbing. Grade 1 obliteration of the angle between the nail and the nail bed and positive fluctuation test. Grade 2 parrot beak appearance. Grade 3 drumstick appearance. Grade 4 hypertrophic osteoarthropathy. Shamrot's sign. When the dorsum of the distal phalanges of the fingers of both hands are approximated to each other, a diamond-shaped gap is made out due to the presence of the Lovibond angle. This gap disappears with obliteration of this angle, as occurs with clubbing. Hypertrophic osteoarthropathy. It is a painful swelling of the wrist, elbow, knee, ankle, with radiographic evidence of subperiosteal new bone formation. It can be familial or idiopathic. Other common disorders that can produce it are bronchogenic carcinoma, cystic fibrosis, neurofibroma, AV malformation. Causes of clubbing: congenital or familial. Congenital hypertrophic pulmonary osteoarthropathy, pachydermoperiostosis. Acquired may be unidigital or pandigital, unilateral or bilateral, differential. Unidigital clubbing. It is seen in tophaceous gout. Local injury. Sarcoidosis. Unilateral clubbing. It is seen in aneurysmal dilation of aorta, subclavian or innominate arteries. Brachial AV fistula. Hemiplegia, Pancoast tumor. Differential clubbing. It is seen in PDA with reversal, with cyanosis and clubbing occurring in the lower limbs only. Pulmonary and thoracic causes: bronchogenic carcinoma, metastatic lung cancer, suppurative lung disease, bronchiectasis, cystic fibrosis, lung abscess, empyema, interstitial lung disease, long-standing pulmonary tuberculosis, chronic bronchitis, mesothelioma, neurogenic diaphragmatic tumor, pulmonary AV malformation, sarcoidosis. Cardiovascular causes: cyanotic congenital heart disease, bacterial endocarditis, atrial myxoma, Eisenmenger syndrome. Gastrointestinal causes: cirrhosis of liver, ulcerative colitis, Crohn's disease, GIT malignancy. Miscellaneous: syphilis, syringomyelia, acromegaly, thyrotoxicosis. Pseudoclubbing. It may be seen in Hansen's disease due to resorption of tissue, vinyl chloride worker due to the focal tissue reaction to the chemical, leukemia due to tissue infiltration, hyperparathyroidism due to bone resorption. Examination of the eye. Horner's syndrome seen in Pancoast tumor, iridocyclitis seen in tuberculosis and collagen vascular disorder. Chemosis and dilation of retinal and conjunctival veins is seen in superior vena cava syndrome and hypercapnia. Papilloedema is seen in chronic obstructive pulmonary disease and SVC obstruction. Color blindness is seen as ethambutol. Examination of neck. Scalene lymph node. It is a group of nodes in the pad of fat on the surface of scalenus anterior muscle just in front of its insertion into the scalene tubercle of the first rib. Significant node. It is one which is round in shape, 0.5 centimeters in diameter and firm in consistency. It is large and fixed in secondary involvement from the primary lung malignancy. Hard and craggy, matted, with or without sinus formation in healed and calcified tuberculous lymphadenopathy. Other significant lymph nodes to be palpated are supraclavicular lymph node. Presence on left supraclavicular node or Virchow's node is known as Croisier's sign. Cervical lymph node. Axillary lymph node. Parietal pleura involvement with infiltration into subcutaneous tissue and skin. Breast and upper limb disorders. Presence of veins over the chest wall. In superior vena cava syndrome, look for presence of distended veins over the chest wall. If the obstruction to SVC is above the level of azygous vein, collateral venous circulation on the anterior surface of the chest wall is less prominent as the intercostal veins drain into the azygous vein. Causes of SVC obstruction. Malignant causes: bronchogenic carcinoma, Hodgkin's lymphoma, thymoma, mediastinal germ cell tumor, neuroblastoma, metastasis from carcinoma breast or prostate. Non-malignant causes: mediastinal fibrosis, TB, syphilis or histoplasmosis, thrombosis induced by interventional procedures, pacemaker catheter, Levine shunt, Swan-Ganz catheter, CV access devices, aortic aneurysm, hematoma, mediastinal sclerosis, post-irradiation. External manifestations of respiratory diseases: asterixis, respiratory failure, halitosis, suppurative lung disease, gynecomastia due to drugs like isoniazid, digoxin, and bronchogenic carcinoma, Horner's syndrome, Pancoast tumor, small muscle wasting, Pancoast tumor. External markers of tuberculosis: tinea versicolor, lupus vulgaris, erythema nodosum, scropholoderma, caused by atypical myobacteria, M. scropholoceum, epididymoorchitis. External markers of cor pulmonale: raised jugular venous pressure, pedal edema, ascites, liver enlargement.